So these are the things we want to cover in the agenda. We want to talk a little bit about healthcare system transformation, some about federal policy, key value-based purchasing concepts. Those are sort of the 101 for those of you who haven't really been immersed in it. We just don't want to leave you behind. We're also I'm going to talk about Pennsylvania and what's going on in Pennsylvania, although most of you probably already know. And then preparing for success. What does it take to really prepare for success in this? What is value-based purchasing? It's a concept by which purchasers of healthcare, it could be employers, it could be government entities, and it also could be consumers, and payers of healthcare, also public and private, hold the healthcare delivery system at large accountable for both quality and cost of care. And I think Meggan pointed those two things out early on. It pays for value, better care, better outcomes, and reduced costs, instead of paying for that volume, which is visits, fee-for-service, procedures, that kind of thing. We are expecting and seeing value-based purchasing grow. It's going to become predominant in the payment method as providers learn how to navigate in this landscape, including Medicare. Medicare is very much driving this conversation about value-based purchasing and value-based care. Next slide. This is sort of a VBP continuum. This kind of reimbursement is transforming healthcare providers, and Medicare has been leading the way in this arena. It strives to transform the delivery system of care by shifting from rewarding volume to which is fee-for-service, to value, which is value-based payments. CMS estimates and has been encouraging providers to move into value-based payments arena, and they continue to define the way that they think, and that by the end of, they're estimating that by the end of 2018, half of the providers will be reimbursed in Medicare under value-based payment arrangements. Driving some of the value-based payment kind of experimentation, if you will, has been the Center for Medicare and Medicaid Innovation, and then which is and also the Affordable Care Act. What people think of the Affordable Care Act as Obamacare, the ACA actually did a whole heck of a lot more than just what's termed Obamacare. There's a whole lot of work around making improvements to the way Medicare and Medicaid operates within the over 12,000 provisions in that bill. So what we have here is this kind of, as we go farther to the right, that's more provider integration and accountability. And as we move up, what you talked about with risk, that goes up as well. So at the very low end, we have the cost-based contracts and fee-for-service. Then in the middle there, we have bundled payments, pay-for-performance, those kinds of things. Moving to upside savings and then both-way savings, which is really, that's where you're not only having upside savings, but you're also sharing in the downside as well.
Are these terms or payment mechanisms familiar to everybody? I don't want to gloss over them. Are there any on here that people are maybe a little bit unsure of the terminology that we should take a moment and describe a little more deeply? Everybody's familiar, comfortable with bundled and episodic payments, capitation, partial and full, right? We're good? Okay. Don't be afraid to say, you know what, I'm not so sure about some of them, because we don't want to sort of, steamroll down the line and start talking about them more if people want a little bit deeper definition.
Richard did tell us that you guys are already familiar
with
101.
Okay,
so,
great. All right, just making sure.
Yep.
Like, I've nicknamed him Rocky, by the way. He's
when CMS or the states create requirements for value-based payment, they are indirectly setting in motion the development of provider-led entities. Are folks here familiar with provider-led entities? Do we need any more information on provider?
ACOs? IPAs, CINs. I was going to make another one up just to see if people were paying attention. XYZs? No, that doesn't. Although that acronym SOUP, networks of providers, those are collectively provider-led entities. So networks of providers led by providers, not just managed by an insurance company or a payer where they're driving the network management, but where providers themselves are organizing into networks and taking control of their own destiny as far as accountability and risk and contracting. We use that PLE as a generic thing because in every state across the country, there's even more new different acronyms for these things, believe it or not. So that's just the big, broad definition of all of these types of networks.
Okay, any questions on that? Okay. The next slide is the quadruple aim. Who's heard of the triple aim? Heard of the triple aim?
Oh, good.
Okay.
Hopefully.
In 2011, when I arrived at CMS, within about 2 weeks of arriving there, then Administrator Don Berwick came and he did an all-staff meeting with, I don't know, there were thousands of people at this all-staff meeting, and he talked about the triple aim. And the triple aim, what he's talking about with the triple aim is enhancing patient experience, enhancing consumer experience, improving population health, and reducing costs. That's the triple aim. In 2014, the quadruple aim was introduced in a paper that was published in the Annals of Family Medicine, and I think this really will speak to all of you. But provider health is really, really important in achieving the triple aim, and so they talk about provider satisfaction, and I call it provider health, provider integrity. All of those kinds of things are really going to be important in order to achieve that quality, experience, and cost continuum. The next slide is what impacts health outcomes, and I'm sure you know all of it. You know these things. 40% is behavioral patterns. 10% is healthcare, actual healthcare. 5% is environmental exposure. 30% less than the behavioral patterns is genetic predisposition, and then social circumstances certainly plays a role as well in terms of health outcomes.
So I like this as someone who grew up in the behavioral health system because I love that. So this was 2007, New England Journal of Medicine published this, right? I feel like the healthcare system, the larger healthcare system, is just sort of waking up to something that those of us in behavioral health and long-term care and other social services have known for a really long time, that whether or not you have safe, healthy, affordable housing has a bigger impact on your health and behavioral health than the 10 minutes you spend in your doctor's visit every 6 months or a year. I feel like the healthcare's world, their minds were blown by this when this came out. It was a really big deal. And those of us who have been in the behavioral health system are like, well, I could have told you that, right? So what this means to me, and I'm sorry, I should have asked people's names when you spoke, but you were talking about sort of this notion of the behavioral health provider and other being pushed out or marginalized from the market by large healthcare systems. Well, guess what? They need us far more than they ever realized they did. And, there's going to be this constant challenge of how do we measure and demonstrate the value of what we're doing. But the science is already there that says that what you're doing in a behavioral health agency is having a far greater impact on that individual's health. And we know that, right? You're stabilizing someone's behavioral health. Guess where they're seeing improved outcomes and savings? In their healthcare. So I love this slide, and I think it's worth just noting that this is actually the assimilation of so much of what we know from the behavioral health long-term care sectors into the larger public healthcare sector. So it is going to come down to how we measure it, but this is already doing some of the work for us. The data and the literature says that it's having a bit greater impact if you can affect people's behavioral patterns and social circumstances and all those things that you're going to impact their health.
Did you have a question? Okay. The next slide, Meggan just mentioned social determinants of health. Very, very important. And as Meggan said, the healthcare world is just opening up and starting to understand what kind of impact social determinants of health have on a person's well-being. Food security, food insecurity is another social determinant of health that we're very knowledgeable about, and then housing as well. I think housing is a really important one. Financial stability, the neighborhood that people live in and their environment is really, really important for health. And that's an area that I think that healthcare providers are starting to wake up and asking those questions. Do you have mold in your home? Or, they're starting to get into questions that lead them down the path of understanding what a person's world is like outside of the office that they're sitting in. You'll probably start noticing that on some of the questions that they ask in the actual visit, during the actual visit. The next slide, key value-based purchasing concepts. I'm going to go through these pretty quickly. First, benchmarking. What is the baseline spend against which the future spend will be measured? So you need to have that baseline, which is a benchmark. Risk adjustment, change to the benchmark to reflect consumer characteristics. So if the person's older, that's going to affect it. If the person has a poor health status, chronic conditions, all those kinds of things affect the risk. Attribution, how and to whom is the care and well-being of the consumer assigned? This is really, really important. So as you think about those PLEs that we talked about, so if it's a provider-led network, who is your care attributed to? And I think that's a really important thing for providers to have an understanding of amongst themselves as they get into those models. Predictive modeling, this is analyzing data to create a statistical model of expected future performance or results. And so predictive modeling is going to really depend, when you asked earlier about measurement, it's going to really depend on being able to measure and agree to what measures are going to be accepted. And then stop loss. This is an upper limit on the amount the provider can lose in a shared risk arrangement. So there's a point at which you can't lose anymore. Does anybody have any questions on these kind of key VBP ideas, these concepts?
I just want to emphasize what Jen was saying here about defining these things very close. So this is the whole conversation. I mean, this slide we could spend. Defining these things. This is exactly where the rubber meets the road, right? What are the risk characteristics we're going to adjust for, from diagnosis to age to other factors? How are we defining the amount of time we're looking at for costs? When was it? What year was it? For what, what's in, what's out? Those are exactly where those negotiations and discussions with the payers are going to happen. And those are the things that you have to be very, very comfortable with eventually. And we're going to talk about how you get there. But you're going to hear throughout this entire thing, right, what are those data sources that you need that you may not have right now to get at some of these things? And if you don't have that data and you aren't able to do some of these key things here and begin to think about, define, analyze, negotiate on these, then you're not quite, then you're taking some additional risk when you're entering into these arrangements. So how do you get these tools at your disposal? What are some strategies for doing that?
Okay, next slide. I'm going to talk a little bit about Pennsylvania, and just to put it into context with regards to where Pennsylvania is. As you probably know, if you've been working in behavioral health, we are a saturated managed care state for Medicaid. For Medicaid, commercial, and for Medicare, we have a lot of Medicare Advantage, and in particular in the southwestern part of the state, there's a lot of Medicare Advantage. So there's already a lot of managed care happening in Pennsylvania. And both HealthChoices and behavioral health choices have introduced value-based payments. So HealthChoices is our Medicaid product. It's been around for more than 20 years. So has behavioral health choices. And in HealthChoices, I'm going to talk first about in HealthChoices. As I mentioned here, more than 20 years. I believe it was 1997 when they first started rolling out. So we really have been doing managed care for a very long time. In behavioral health, we have a carve-out model. And also started in the mid-90s. And then Community Health Choices, which is the new Managed Long-Term Services and Supports program that's operating under the Office of Long-Term Living, is a different kind of managed care, and it is rolling out in phases. It launched in January in the southwestern, 14 counties in the southwestern part of the state. It'll be moving to the 5 counties in the southeastern part of the state in January of 2019, and then it's going to move to the rest of the state in January of 2020. Because community health choices, I'm just talking about community health choices, is nascent and it's just getting started and it's just getting launched, there are no value-based purchasing, value-based payment arrangements within the contracts that the state has with the 3 managed care organizations at this time. However, if you want to do some light reading, you can look at the agreement, which is the contract that the state has with the managed care organizations. The language is there. It's going to happen, but it's going to happen downstream when they're really at a steady state in terms of having managed care and having launched managed care and feeling like they've really. So I think providers who are providing services in MLTSS and community health choices really do need to be thinking of the future of when value-based payments start getting introduced, because it's going to happen. And it's likely that the state will follow the model that they're doing in health choices, although that's not guaranteed. And let me just talk a little bit about health choices, which the department requires health choices, MCOs, all of those MCOs that are participating in health choices, they have to report quarterly to the department on their value-based payment arrangements. In this year, 7% of all of their payments need to be value-based payments, and they report on those value-based payments on a quarterly basis now. June 30th of the year following January of 2017, when this got launched in Health Choices, that June, all the MCOs submit a report to the Department of Human Services, which details their value-based payment arrangements. What kind of providers are they using? What kind of contracts do they use? And are they getting to 7%? If they are not getting to that 7% in value-based payment arrangements, they will get dinged. Basically, they're going to use the previous December payment, the PMPM, per member per month payment, and reduce it by 1%. So that's what's going to happen to the MCOs. So those MCOs are already engaging in value-based payments in health choices. The 7% is going to go up and up and up each year. They're planning on introducing more. It'll go to 15%. I don't know the exact numbers, but they are moving towards value-based payments in health choices, and they're doing it. The health choices strategies are, we talked earlier about pay for performance, which is a direct provider payment for achieving quality goals. They also have patient-centered medical homes, which is care coordination payments, direct provider payment for services, and total medical costs for attributed patients. Shared savings arrangements are another kind of value-based payment that they have. And those are shared savings payments, obviously direct provider payments for services, and total medical costs for attributed patients. They also have bundled payments. We had that was on the rocky steps there. Bundled payments are direct provider payments for services, and full risk and ACOs is the highest level that they have in health choices. And I will say that the department is definitely going down a path of continuing. I think they're going to be continuing as they go on. OMSAS also they're about a year behind Health Choices, so that's behavioral health choices. The next slide here, through the Office of Mental Health and Substance Abuse Services, the Commonwealth is definitely encouraging providers and behavioral health MCOs to transform as well. As you know, in Pennsylvania, MCOs are contracting with either the county or the county, I don't remember what the name of it is, but a county group of counties. But the state is driving requirements around value-based payments. They want to change how care is delivered. They want to achieve better outcomes and higher quality. Obviously, they want to bend the cost curve. Meggan talked about that as being one of the most important things in driving towards value-based payments. And they want to incentivize purchasers and providers by paying for value, not volume. Next slide, this is the value-based purchasing framework that OMSAS talks about. There are slides on the OMSAS website that you can look at that really talk about that, but these do go, these are sort of the steps from small risk to large risk. They have performance-based contracting, they have bundled and episodic, which is sort of a medium risk, shared savings, shared risk, capitation, and capitation and performance-based contracting is their highest risk. So those are OMSAS's, that's OMSAS's framework for value-based payments.
I just will say that, so almost every state in the country now has some framework like this, some similar set of what they call levels of value-based payment, and they may define them slightly differently state to state, but for the most part, they're very, very consistent. And we frequently talk about the fact that we highly suggest providers really go through these steps relatively in order or linearly. We don't generally encourage providers to do full capitation if you've never done performance-based contracting of any kind, because that's sort of a big leap for you. And so really getting at the sort of step-by-step, do I have control of my quality first and my performance, then do I have control of my costs and have the right cost data, and then moving through that, and then do I know how to do a shared savings arrangement? And I will say that there are many instances in many states where payers are actually willing to go with you into an upside savings arrangement only because they're willing to work with you to learn. It's not just providers who are learning how to do that. Payers are still figuring this out. They do not have it all figured out. So we will talk about what we know that they care about because they have to. Sometimes it's dictated to them by federal requirements, by state contracts, by other things. But in many cases, there's a real opportunity if you're willing to be a little bit of an early adopter and do some of these things and work towards these types of arrangements that you can enter. I can tell you in New York, we're seeing a lot of this where the payers are willing to go into sort of pilot testing arrangements of this to really work through the steps of are we agreed on what the quality measures really are? Are we looking at the same data to determine cost? Do we agree on the definitions together, and let's figure this out before anyone's at risk? It is not in their interest to put you out of business. That's really not the goal of all of this, although I know it feels like it sometimes because the increased demand is so great and the risk is greater. But I just wanted to say this is consistent nationally. Some states are further along than others, but this really does reflect where the entire system is going. And so far, this administration has not made a move to undo this, even though it was sort of set in motion primarily by the previous administration, and I mean the previous federal administration, and by the ACA. I'm not sure people associate this piece of it with that, and therefore it hasn't been attacked in the same way that other provisions of the ACA have been. So we have not seen efforts to claw this back. It really is quite a capital-driven paradigm and approach, and so we don't have a reason to believe that they would attempt to undo this. They're moving forward aggressively, CMS is, in negotiating with states on commitments to moving more and more and more of their Medicaid and Medicare payments under these arrangements. Yeah.
Given that in Pennsylvania, we function under the separation system of
Yeah.
physical health, behavioral health, and yet in all of the value-based and on the other hand, the whole move is integration of healthcare.
Yes.
You're doing both of them, you're not getting,
Yes.
How is this going to fit?
It's a great question. So in this varies state to state too. There are still lots of states that have their payment systems separate for behavioral health and for other health, acute and primary care medical services. It is important because taking on risk on the behavioral health side without any integration or access to savings generated on the healthcare side is problematic. So that's an example. We can talk more about that if you'd like, but absolutely that is an issue. And so, as you know, many states are moving in the direction of integrating their funding because there's a notion that will then drive down to the provider level better integration of care across the, on the street, really, interfacing with consumers. We don't have a lot of proof that that has really, really occurred systemically yet. But it's a good question, because you really do, if you want to ever get to these sort of larger capitated arrangements, you need all services in that bucket to really look at, because one, you're sort of pushing on one lever to make changes in another. In some cases, what we see, and this is the danger for behavioral health providers, what we see is behavioral health providers taking on risk or moving in this direction and doing an amazing job. And guess what happens when behavioral health providers do a really, really good job of engaging people? Behavioral health costs go up, at least for a while. At least for a while, because you've got pharmacy costs because people are engaged and taking medications more consistently. There are attending outpatient visits. You will start to see some reduction on the inpatient side and the ED side. But where you really tend to see the dollar impact, and there's quite a bit of data on this, is actually on people's health care. They're going to the ED less for their diabetes and their asthma and their other things because they're better managing their depression or their schizophrenia and are engaged in care for those things, and that allows them to also participate in better management of their health care. So you make a very, very good point, which is, and there are examples all over of where this has actually been a problem or failed, where special needs plans that only are limited to behavioral health or long-term care or developmental disabilities take on risk, and ultimately, because they can't access the savings on the healthcare side, are not seeing the same kind of savings that they expect to. And that's a really, really important point. So that needs to be a part of the discussion in any of these arrangements.
Can I make a suggestion?
Please.
Richard, you just joined the room. Hi. Are you sponsoring the deputies coming in for a panel at any point?
Yes, Thursday morning, all the deputies.
Okay, that is a good question to ask the deputies.
Excellent.
We're talking this because we actually have to do measurements on the physical health side.
Yes.
It's non-reversible to it, but we still have to do all the work.
Yes.
It's very, very conflicting right now.
Yeah.
Understood. You're right, and that's another thing which is driving when we're frequently asked about what should people be measuring on the behavioral health and long-term care side. Unfortunately, frequently, I don't know if it's unfortunate, but the challenging piece is frequently the answer is healthcare outcomes, actually, because that's where you're going to see savings. That's where the managed care companies are still much more comfortable with measurement and outcomes. And so frequently for behavioral health providers, you start to get into the business, like you say, of measuring the impact on the physical health side, because that's a demonstrable impact that payers appreciate, that is more consistent and standardized across the system.
Okay. Any other questions on that slide? Okay, we're going to go to the next slide. This slide talks about the rollout in the behavioral health managed care arrangement. So in year one, which we're in right now, 5% of the contracting needs to be in any combination of the 6 models that we had in the last slide. In year two, which is 2019, at least 50%, well, first of all, it's 10%. 10% of payments need to be in value-based purchasing in year two. And within the 10%, at least 50% of that 10% must be from a combination of models 2 to 6, so moving up the continuum into more risk. And then year three, which is year 2020, calendar year 2020, 20% of the payments will need to be in value-based payment arrangements, and at least 50% of that 20% have to be from combinations of models 2 to 6. Similar to HealthChoices, beginning in 2019, June of 2019, all the behavioral health MCOs will be required to submit evidence of the actual value-based purchasing arrangements to support the evaluation of outcomes. And the general strategy, and this is in terms of an evaluation, along with this 3-year rollout goes an evaluation. The state is tracking all of this to really evaluate the impact of it, but these are the components of that evaluation. So they will want to be seeing in the reporting. The MCOs will need to make a list of all of the providers that are anticipated to participate in value-based payment arrangements. They would want information on the targeted populations and/or services that are anticipated to participate in VBP. the amount of medical spend that each VBP contributes to the overall VBP plan, total expected primary contractor medical spend for each year, and then financial assurances. So these are all things that the state is going to be looking
This is
for in
huge.
terms of an evaluation.
This is very specific and very important, I think, just to make sure that you're aware of this and note this, because this is more clear and prescribed than many states have articulated these. I think that's a good
Yeah.
thing in Pennsylvania right now.
It is.
I'm sorry. Yes, absolutely. I think it's online already, maybe. If not, it will be any moment. No problem.
So this is the general strategy. Each MCO has had to
Sure.
submit and get approval of an implementation plan. That happened for this start in calendar year 18 at the beginning of this year. And then speaking to your question, there's a lot of discussion about collaborating with the physical health MCO. And the state is really starting to put requirements in their contracts, both on the behavioral health side and the physical health side, around collaboration and requirements around what does the communication look like, what kind of electronic health records are you sharing. Those kinds of things are starting to be articulated by both the physical health contracts and the behavioral health contracts. And as they move up that continuum, more of that will be, you will be seeing more of those kinds of requirements around collaboration. So that's why I suggested that you ask the deputies. They have in mind to do this, I know that. Okay. So finishing up on Pennsylvania, the behavioral health MCOs are expected to assess provider readiness to participate in the target areas for the VBP. They are also expected, the MCOs are expected to assess the extent to which provider network has capacity to move along risk-reward continuum to achieve those quality outcomes that we talked about at the beginning, and also cost efficiencies within this 3-year period. And then the MCOs must demonstrate that they plan to provide training and provide technical assistance to providers. So that all has to be laid out in that implementation plan. Yes.
Yeah, there's several MCOs in Pennsylvania. Is this process standardized across the MCOs? Or?
Bless you.
I'm sorry. I knew it was coming.
Standardization across the MCOs. So the state has some basic level expectations that they're promulgating, but there's still a lot of flexibility
Yes.
across MCOs that's allowable to them, which is a problem everywhere.
Yeah.
Well, especially when you have 3 MCOs, you may have 3 MCOs
Yes.
you're dealing with, and it's the same service.
Yep,
Yeah.
I agree.
It's just, I mean,
So that's another thing. Yes.
who and
Yes.
how it's going to affect providers as a whole.
I agree. As much as you can push your state policymakers for standardization, they are frequently hesitant to impose too much standardization on payers. They really do create problems system-wide for administrative inefficiency and redundancies. When they don't do that, I can speak to that. There are several other states I work in where they haven't done enough standardization. It's a little bit of a free-for-all, and it takes a lot of time to iron it out and a lot of cost.
Well, the thing is, that it would a lot of cost is because your providers are going to be more hesitant to take on a higher risk.
Yes,
If you're taking on a higher risk for this MCO,
right.
you have the same service over here
Yeah.
with another MCO. Just
Absolutely.
Yeah.
for budgetary and maintaining programs.
The other issue is when you're thinking about value-based payment arrangements, and someone already raised this, and I'm sorry, I don't remember who earlier, the volume of attributed lives that you share in common with a single MCO and the membership, right, needs to be sufficient to distribute that risk across that number of people and services. And so that's really what Jen was talking about earlier with networks forming of providers, is really to achieve that economy of scale and volume sufficient to distribute risk. So it's not just provider by provider by provider, and that you don't have 300 providers to 11, 20, whatever number of MCOs that would map to. And you can really begin to say, we're a network. We're going to interface with an MCO as a network. We're going to work together and collaborate as a group of providers. And so we're going to get even a little bit more into that as a tool, not the only strategy, but one important strategy to get to that level of, let's make this a unified front and work together to interface with that MCO. And that can help to streamline some of those requirements and interfaces. I'm sorry, you had something in the back?
Yeah, I understand the concern, but I'm not sure I agree with it.
Okay.
Like you said, the payers don't know what's going on here as well, and I think
Correct.
they're trying to test a lot of things.
Yes.
And I think we're gonna see a very narrow, if there's utmost standardization, I think we're gonna see a very narrow examples of value-based purchasing. I think one of the benefits of allowing the payers to do different things is that there's some A/B testing.
That's right.
Sure, absolutely. I don't disagree with that. I think there's probably a balance between over-standardization and still allowing enough innovation and creativity and figuring things out between providers and payers at different levels, absolutely. Yeah, it's a good point. Yeah, hi.
I'm going to do the worst thing. This is the beginning and this is the end, and they random comments.
Please.
So maybe we covered this, but I'm trying to do all three at once. One of the things that we just touched on that in the last couple months I've heard more about than in the past 6 years is how value-based purchasing arrangements payments can really start to push the whole concept of a behavioral health carve-out. And that's beyond the scope of today, but it's something to keep in the back of your mind because invariably these alternative arrangements could drive improved quality and decrease costs in and of itself. But a lot of models, the savings comes on the medical side.
Right.
And as that happens, how do you start to share the funds across these companies?
Yeah.
So really the same, the carve-out, if that's what people really believe in, somehow that has to be addressed. And this is nothing new. I point out back 15 years ago when I ran CBHD, I remember one large provider system came to me and said, we can do all these things, if you can create new funds, we could significantly reduce emergency room admissions. To which I responded, I don't pay for emergency room admissions. Why? I hate to be so capitalistic, but why am I funding this?
Sure.
And so those kinds of things
Yep.
Yeah.
issues.
Goes back to
Absolutely. Yes. And that's going to be something that the payers are going to have to wrestle with, right? If they know that they have, that managing the behavioral health of their members has a significant impact on their bottom line, even if behavioral health services are carved out over here, they're going to have to navigate that. At what point do I have to invest as a payer differently in services, or as a healthcare system, if I'm now being accountable for the healthcare of a population that's attributed to me, all of a sudden I'm going to care about whether their behavioral health is managed for those people attributed to me, and they're going to have to partner differently. And so that drives, in some ways, the healthcare systems becoming a new purchaser of your services, of behavioral health, of long-term care, of other things, right? Because all of a sudden now they have a vested interest if they're being held accountable for risk and quality outcomes and working with you in a different way maybe than they have before. And so that gets at, how do you become an appeal, it's a potential marketing and growth opportunity for long-term service providers and behavioral health providers to sell to the healthcare system, hey, listen, there's a group of people that you're serving, that you're accountable for, their health outcomes, that we're also serving. What is that? How do we partner together? What does that look like? How do I help you achieve your metrics? And we, get better integrated, coordinated care for the people we serve, which, let's remember, theoretically the point of all of this, right, of moving into these alternative payment methods and value-based payment arrangements is actually to improve the quality of care for people that we're serving and their health outcomes. So, yes, I'll just leave it at that for a moment. Yes.
To make it even more difficult, additionally, in Pennsylvania, the counties play a significant role.
Yes.
And in our county, they control the behavioral health Medicaid dollars,
Mm-hmm.
very directly, more so than physical health.
Yep. Sure.
And that creates difficulty. Something's going to have to be adjusted there. I don't know whether this is going to mean the counties are going to lose some of their control in the long run.
Frequently, that is a trajectory of the systems. I can tell you that happened in New York. As a formal local government administrator of behavioral health services, we did start to lose control as services were carved in and integrated in our state. And so then what is the appropriate, meaningful role for local government and counties to play in that system? There still can be lots of different roles that they can play. They just may not be in the management and funds flow the same way that they were before. Absolutely. All right. Sorry, go ahead.
Not really looking for an answer now, but to pose a question maybe.
Okay.
Because I see this applied to us as providers as well, that we may have an individual that's given services. Right now, we get clearly a fee-for-service reimbursement.
Mm-hmm.
Eventually, when we're in a capitation or a bottom rate, we get one payment for that person. How do we
Correct.
assign that to the individual programs?
Exactly. That is the exact question. Yes, so we will talk a little bit because I'm working with a few IPAs in different parts of the country where they're wrestling with these exact questions. Is this methodology of this question sort of who gets credit for what, right? I'm doing this thing, how does that impacting? If you've got a care management provider, a behavioral health clinic, and a primary care provider, and the person's health improves and they don't go to the hospital, who gets credit and money and, gets some of that shared savings claim? So absolutely, yes, we can get into that a little bit more. Yes, sorry. Sorry.
As you're talking about all this, it seems to be begging for ACOs and IPAs.
Yep, to get together and play in the sandbox, yes.
We are really going to be challenged to be able to not only negotiate, but have a big enough pool.
Absolutely.
So maybe at some point, as you're talking about the success, that's really a realistic assumption. These providers that have been very independent, particularly in Pennsylvania, how do you create a path for collaboration where that is an essential part of succeeding?
Sure. Absolutely. I can give you some examples of that. Yeah. So I can tell you, there's another thing. I was just gonna say for this panel of your commissioners, we're gonna get them all queued up with questions, right? They're gonna love us. And I can tell you that because New York over aggressively committed to CMS on how much of their public funding they would move under value-based payment arrangements, they dumped literally billions with the B into a system that was largely hospital-driven in our state, very much large healthcare system. And some of us who work in that state questioned the logic of shifting costs and healthcare seeking behavior away from inpatient and ED by giving all the money to the hospitals. So they realized, maybe a little too late, that they actually had to really invest in the community-based and behavioral health sectors in order for the behavior to really change and to start to shift from this institutionalized acute emergency crisis care into ongoing ambulatory rehabilitative supports in the community, which is in theory the way that you drive and create value in value-based payment arrangements, right? So the idea was that they actually took a whole bunch of money, $60 million, and they said, we're going to hand it out only to networks that meet the following criteria. And so they had a requirement for a lead agency to apply on behalf of a network, and it had to be a licensed agency by one of the mental health, substance use, one of the what we in our world call the O agencies: Office of Mental Health, Office of Substance Abuse Services, Office of Child and Family Services, Office of Developmental Disabilities. So they said you have to be licensed by one of those, and you have to then your network has to meet all these criteria. So you have to have a provider for everything. You have to have an outpatient mental health provider. You have to have an outpatient substance abuse provider. You have to have a housing provider. You have to have a health home in there. You have to have a whole bunch of things. And the state actually issued this and said, here's a 3-year plan. You've got to meet these milestones. And there's a set of deliverables around clinical integration of the network, quality improvement, data sharing, the whole range, and it's sort of a set of things. And they said, because otherwise basically behavioral health and community-based providers were going to be left on the curb, and hospitals were going to keep driving it, and we were never going to get where we needed to go. And so the issue of who does that investment? Is it the payers? Is it managed care? In some cases, managed care is ponying up more money to pull behavioral health providers into networks. In some cases, it's states. In some cases, it's local governments. In Massachusetts, they made a whole part of their delivery system reform waiver they actually dedicated a whole chunk of it to behavioral health and community-based organizations. So everybody's doing this a little different, but without some incentives, some payment behind it, some money, it's really, really hard because it takes time and energy and effort to build the infrastructure for these networks, or else they're not that useful, right? And you've got to be able for them to gain and build the sophistication to interface with an ACO or a managed care company. There really does have to be a there. They have to come together. They have to have some meaningful data sharing and quality work and all of that. And so I think another question for your state is, if you want us to be involved in this at all, where's your investment going to be in this sector? And maybe there's some other state examples we can give you for where they've done this, so you can put a little pressure on them to do it for you. This we already talked about, so I'm not going to dwell on this. You know that you're pushing the risk further and further down, right, to the provider level. And so what does that mean? As a provider, if you've never had to take on risk, I mean, most of us, many providers, I don't know about, at least in the systems I've worked in, are lucky if we have 60 days cash on hand because of the poor funding that we've gotten for so many years, let alone capitation to take on some kind of risk, some little level of capital reserve. So that is of concern, and that's another place where coming together and partnering really does help to build that resources, so you have a much broader network of resources. You also need to sometimes make the payer be the one to hold that risk for a longer period of time, right? To say to the managed care company, until we've figured this out, we can't take the risk on, right? Because so you need to have some of those protections in place. Or you can take, let's say we can only take small risks to start. Let's start 5%, 10%. And this really is how it's going around the country. Taking on small windows, but showing that you're willing to have some skin in the game, because that is important. And frequently, in order to get that upside shared savings, you've got to demonstrate that you're willing to take a little bit of heat too, right? To have some skin in the game, to say, I will put some of my funds at risk to demonstrate to you that I'm, and also they believe that you're going to work towards those quality outcomes and those cost saving measures. So these are the kinds of things that they want to see as they enter into these arrangements. We've already talked about population. We haven't quite yet talked about what information, only high level, right? Do you need to do this? If you do not have access to real-time population level data on the people you're serving, then this is not possible. And so the next level of infrastructure that we really need to talk about is real, meaningful, timely, current data, meaning and including alerts from acute systems when the individuals you're serving are going to the emergency department, showing up in different systems, the crisis systems and emergency systems. The type of data sharing and data warehousing where you can, it's another thing a network can do for you is the piece of data that you have about the people you serve is very incomplete, right? So there's new pieces of data, access to new types of data that you've never had before that maybe by yourself are not practical. But coming together with other partners, whether it be a larger healthcare system, a payer, or other among you, and coming together as a group collectively to say, hey, let's figure out how to get access to claims data, right? We have to understand the cost piece of this. Guess who has claims data? Payers. In some cases, the state is actually giving it to providers in certain arrangements. I don't know about you, but New York their lawyers are way too conservative for that. We haven't figured that one out yet in New York. There are other states I work in where they have done more, where they've pushed out more Medicaid claims data to providers. Keep working on that. We're going to keep working on it. But they also really, really depend on this three-legged stool, which you probably see. Everybody's got a different version of it, I'm sure. But this sort of coordination and work. So then you start to have more pieces of the puzzle. If you're working together and sharing that data across these systems, you actually start to see things like, hey, I've got someone who's stable and they've been more engaged in treatment and their depression's managed, and now look, their asthma and their diabetes is improving. Those sorts of things that you can actually share across populations with other providers. So in the beginning, we say, be careful, go step by step up the ladder. You don't have to go as fast as Rocky up the stairs. You got to go step by step very deliberately, but you do want to think about the future of what you're negotiating for and practice for that future, right? They say dress for the job you want, not the job you have. Be doing data analytics and looking at the quality of your services and your performance capacity in a way now that will prepare you for that future, not just the one step in front of you. And that's really critical in succeeding in this. And Jen hit this, so I won't overdo it, but it's not optional. Everybody's doing this, going there. There is benefit here to being first mover. I do believe there's a first mover advantage here. And that is that you will have more negotiating room, you will have more trial and error, you will get more generous, I believe, negotiations in the beginning because everybody's figuring it out together. Remember that the payers need you. They don't largely understand a lot of this themselves yet. And really, really strongly have the foundations. And this is, we're gonna go through, we've broken this into a couple different domains that are really critical. We've talked about organizational leadership, having people in place who are both aggressively pursuing this, but understand the risks and are engaging your board at every level, or your staff that are understanding the paradigm shift fundamental to doing this work in a different way and getting paid in a different way. Population health management does not work without care management, complex care management, and that means being able to assess the risk and all types of doing a standardized, validated assessments of people that you're serving, including on the health side, even though you're not a healthcare provider. It means really triaging and stratifying people by risk, right? And understanding what that means, putting them into categories and intervening because of that. Partnership agreements, really working closely with your other organizations. Time and staff resources, something we haven't always done in our system, if we're honest with ourselves, are clear mapping of these clinical workflows and saying this is the best practice, we know it works, let's map it out, let's follow it, because that's the only way we can really measure if it's working. If you're doing the same thing consistently over and over and over again, that's how you start to actually gain data on your performance and understand what's working, what you're doing that's actually causing those quality outcomes instead of maybe you just had a good lucky year. And then the fiscal workflows are the same thing, because we've also traditionally not managed or monitored our costs in the same way that other parts of the healthcare system have had to do. And so that's a new thing, and we're going to get a little more detail into that. I cannot emphasize enough the IT infrastructure, the bones, the skeleton under which you will need to do all of this, and I would say engaging early in the process as you start to, a lot of times what we do is it starts at the administration level, and you're a lot of negotiations, high level stuff happening here, right? And you're talking to the managed care companies, you're doing all this, and it's really great on paper. Looks good, sounds good. Even got the data to back it up. And then you get down to the implementing it at the clinical level, and all of a sudden 10 things that nobody in administration thought about come up of why it can't work, won't work, or needs to happen differently. And so then you've got to revise, revamp. Clinical leadership involved very, very early in the process. When I have seen that happen, it makes a huge difference. And just having a sense of your organizational risk tolerance. This is about your board and you and the organization as a whole. We're by nature of what we do, we're kind of analytic nerds about this stuff, but we highly encourage you to just be able to really know and have your data inside out and backwards from the cost and quality perspective, the community perspective, what will the community bear, what are the demands, where opportunities for you to meet needs that aren't being met, and understanding the underlying data. Do you know who, we think we know who the provider is down the road in our system frequently, but do we really know who else is providing behavioral health? Because sometimes it's surprising. It's not always the other behavioral health providers that we know, but we find that healthcare systems are doing more and more themselves, and they're building it in-house. And do we really know what they're doing and how they're competing with us? So all of these things are really important in order to enable and facilitate any kind of value-based payment arrangement strategy. And so I'm going to pause for a second. I'm going to maybe do one domain and then we take a break, according to my clock, and then we'll finish with some of the other domains. This first domain is organizational leadership and readiness. So doing this is a cultural change from traditionally how we've been delivering services. It's not just a back-end payment system. And if we think of it as just a back-end payment system, we're going to run into trouble. It is a fundamental shift now tied very closely to the idea that payment incents behavior change, right? What we pay for, we get. That it's not just at the clinical level, but every level of the organization. So I've already mentioned board engagement important earlier, and often it will take them a while to get this if it's new to them. And so it's going to take recurring communication and engagement with them. And they're not going to realize, I think, how much this is an impact on what you do and how you do it. Make sure you have the tools at your disposal to really see and review at a consistent basis, real-time basis whenever possible, the type of data you need, because you need those when you're exploring taking on risk. You need early flags, early warnings, early data that shows you that something's not going the way you expected, to course correct, to make changes. If you're trying to achieve those quality outcomes, if you wait for a 6-month report, it's too late, right? You're not going to be able to make those changes that are really going to impact your organization's ability to hit that quality measure for the end of the year. And then when they do the reconciliation, you may be surprised that you're not getting your quality bonus payment. So that's really critical. Partnership readiness. Oh, I'm sorry, Richard, go ahead.
Related to this, you said earlier that you should know your risk tolerance.
Yes.
And that was a nice way to say it. I think what you're really saying is, and it better be high. Because it keeps hitting me with this, that, well, you're a self-selected group, you chose to be here, so you're probably getting there. But no one's being given the choice. Do you want to venture into this or just do business as usual? That's not the choice. It's
No.
how are you going to do this? And we can't predict the future, but to the extent that we can, this is the game now. This is where it's all headed.
Yeah.
So to say, well, I don't know if we're going to be ready for the risk of, okay, then we'll work with this provider.
Right. Right. And it's okay to say that right now today, my risk tolerance is still kind of low. So I'm willing to dip my toe in the water and start here now and try something and learn from it and build my risk tolerance. But I better be working to build towards a point of in 3 to 5 years, I can take on more risk. And if I'm not working towards that, and in order to get there in 3 to 5 years, you've got to start now. That's the other thing. This takes time to get there. It takes time to know your own data and your performance this well and your own costs and all of those things if you're not already there. Partnerships too, this takes time. Building the right partnerships, right? No provider is an island any longer. You can't operate in a system in your silo and do this, right? Because as we've already talked about, the benefits may accrue somewhere down the road. You could keep doing an amazing bang-up job on the services that you're doing and serve your consumers perfectly and brilliantly, and they could be getting better. And guess what? Someone else is cleaning up on that and getting all the shared savings potentially that is accruing. And it could be the managed care company if they're getting the capitated rate, right? And that doesn't seem fair. So part of this is about me wanting providers to get their due, because you're the ones actually affecting people's outcomes and whether or not they're going back to the hospital and what their costs are, and I think that you should get a piece of the pie. So I'm a little biased in that regard, but that really is, the partnership piece. The other thing I say here, and this is not, the payers are your partner. They have to be, and I'm not sure, I know in our system, it's been a very, very, very adversarial relationship for a very long time. It still is in many cases. And so what we work to do a lot is to get people in a room and facilitate conversations where everybody realizes, right, negotiating 101, if we make the pie bigger for everybody, then we all get a bigger piece, a bigger slice, right? Instead of this notion that you're trying to make money off of me and I'm trying to take my little piece of it and wrestle it away from you. Which is not really what's happening here. What we're trying to say is better outcomes for the consumer, lower costs for the system, and then everybody gets a bigger slice and hopefully lives happily ever after. That's the little fantasy world here, right? So the conversation can be a collaborative one with the payers, especially now in the early stages. Don't wait until they've done tons of analysis, have lots of experience on this, and then they have all the data to back it up and are negotiating with you, and make sure you're there at the table in the beginning and looking at the data with them and figuring that out, because that's going to position you long-term to take that piece. I do believe they will only get better at this, and they will do it quickly. They will learn, because as soon as there starts being more money to draw down, they will throw resources into understanding the data better, which is why we also have to understand the data better. And if we work together to do it, then hopefully that everybody wins. But we're going to kind of try to be responsive to your questions and go out of order here a little bit. So I'm going to take a moment and address one of the earlier questions, because we're getting into this really, I think, getting into the nitty-gritty about measures, right? So I think nobody here disagrees with the fact that clearly defined, closely monitored performance and quality measures are a cornerstone to this work. I think the question, right, that comes up over and over and over again is, okay, so what do we measure? What are the metrics? So the good news is that you don't have to come up with your own. In fact, please God, don't come up with your own. And I mean that with, I've worked with a lot of providers, and they bring these tools to me and say, look what we made, and we do this survey or we do this, and it's well intended, but it is not as practical in an environment where payers are really looking for standardization and consistency across a network or across a system. If you make up your own, they cannot compare you to anyone or anyone else or anything else. And so that's one of the challenges here, right? The other thing is that the past several decades in the healthcare industry have been spent by experts, and lots of them sitting around tables standardizing measure sets. Is everyone now familiar with the HEDIS measures, right? That's sort of now common. I know they are not perfect. I know they are not particularly well suited for behavioral health all the time, or for long-term care, or for other aspects of the healthcare system. But there's a couple of key things. One, in most states, they are definitely reflected in the managed care contract. They are definitely, if there's payments or withholds or public evaluation of managed care organizations' performance, they are tied to those measures, so they care about them. Now, there's a lot of them, so there's a lot of variation within that. And we have something I can pull up in just a moment to show you that we have compiled, which is really an inventory of standardized measures, right? And we look at the HEDIS measures and we say, we tell providers to ask some very critical questions. First of all, the question of what do your payers want to see? What do the managed care companies want to see? Well, unfortunately, there's nothing we can do about the fact that the big three are things that they care about. They do. These things drive cost, they drive utilization, they are embedded and ingrained within the managed care system in this country. They're not going away anytime soon. The question of what else and how do we connect what we do to these measures are the right questions to ask, right? So, for instance, there are other things they care about. Primary care visits. Again, the absence of a primary care doc or absence of regular primary care visits is one of the bigger indicators of poor health, right? So even though you're not a primary care provider, knowing whether the people you're serving are going to primary care is another big piece of the puzzle. We talked about the fact that even as behavioral health and long-term service providers, you should know something about the health of the people you're serving, right? And not just because of the terrible statistics that came out 10 years ago that said that people with serious behavioral health needs are dying 25 years sooner, which they are, and they because of comorbidities, but also because that's what people measure and what the rest of the healthcare system is looking at. So we have a framework here. I don't know if that's what we should call it, is a logic that is about connecting your work and your outcomes to these outcomes, right? So if the sort of second degree of separation, I'm looking at what you're doing in a way that you can meaningfully demonstrate is impacting these other things. And so we use this example for housing providers, right? So let's say you are doing housing advocacy work and provide tenant representation in housing court. Talk about which leads to people remaining stably housed. Again, you have the literature on your side because the literature says that people who are stably housed have better health outcomes. You connect that to the prevention of key things that are easily countable, measurable, trackable: exposure, infection, access to primary care, accidents. Substance use is another one here that is in our world is a more easily managed and measured thing that you can then reflect back. Reduce substance use, of course, which causes an increase. All of those things cause increases in emergency departments. So what you're doing is saying, how is the work that I'm doing related to the core outcomes and measures that the managed care companies care about, and being able to connect those dots. So someone came up to me. I lost you. In the break we were just talking about. Sorry. Oh, okay. She may have stepped out. All right. No. Okay, there you are. About behavioral health case management and understanding. Oh, there you are. About behavioral health case management, and said, you know, how do I fit into this? And it's a really good question, right? And but what you told me was a really compelling story immediately about the work that you're doing to divert people from hospital and emergency departments and connecting them to access to care in the community. And those things are very measurable and very enticing and very appealing to payers and have a lot of value. The question becomes, to whom is the benefit accruing for what you're doing, right? So who in this system gets the attribution for the people that you're keeping out of the hospital? Who then ultimately is taking on the risk for the people that you're keeping out of the hospital? If you know the answers to that, all of a sudden that's your client, that's your new customer. That's who you're marketing yourself and your services to, and your data and your impact, right? Because all of a sudden now somebody else is at risk and getting paid to keep your clients, consumers, out of the hospital. And so you have a value add to that person who's now very much financially at risk for that person. And if you don't do what you do, their costs go up. And so those are the conversations and sort of figuring out where in the system, who's taking that risk, to whom are those people attributed, and that becomes my customer in a different way than maybe it has been in the past, whether it's a healthcare system or an MCO or somebody else, but really getting at who that person is that's accountable. Do you want to say, I don't know, something about this, or do you want to?
Yeah, I wanted to say something in terms of measuring in the home and community-based world.
Yeah.
Home and community-based services don't have standard measures like HEDIS measures. And so, but there's a lot of work getting done by the National Quality Forum.
Yes.
They're doing some measure gap analysis on measures that are out there. There's work being done by NCQA on quality measures for home and community-based services. But in terms of thinking how you're going to select performance measures in a home and community-based environment, for example, personal assistance services, which people in long-term services and supports, that's the primary service that they receive, is somebody to help them in and out of bed. I'm not talking about behavioral health, I'm talking about physical health. But the different big measure domains that are being looked at are structural measures. For example, do you have an adequate workforce for providing personal assistance services? That might be a structural measure. Access measures, how do people access the services? How quickly can they get into services when they need them?
Right.
A third domain is process measures. You know, what are the steps that you go through? How long does it take? You know, how many days are required within a contract in order for you to make your first care management visit, for example? And then outcome measures. And those are really the most elusive ones, is how to measure outcomes. And then also to tie them to the ED visits, hospitalizations, and readmissions, which are the big three that the managed care companies care about. So it's very, I would say in the home and community-based world, measurement is evolving. And you guys you're in a position, if you provide home and community-based services, you are in a position to drive some of the conversation because you do it every day. And you know what's important to the consumers that you serve. So.
The other thing we were just talking about on break was engagement. So I was talking with the medical director of a large national health plan. And he was a pediatrician by training, but had worked in one of the large plans for now quite some time. And he said, you know, one of the problems why we have trouble paying behavioral health care providers more, and he was talking about their commercial line of business in particular in this instance, but one of the issues is people don't stay in care. They don't come back. And so for a managed care company to pay you when they're not seeing that return is difficult. It's difficult for them to justify their numbers, their actuarial analysis. And so, you know, what he said to me was, all I want providers to do is keep people in care, keep them engaged. If you can get someone to come back for 3 visits, 6 visits, 9 visits, 20 visits, again, the data is behind you on the behavioral health side, that we have a dose response. We have data that says you stay in treatment longer, you will be an accrued impact, a benefit, right? So MCOs frequently have said and complained to us and said people don't go back for care. That engagement metric of how many times people are returning, coming back, staying, length of stay in outpatient services, in rehab services is huge. And so they don't know how to do it. They don't have the answer either, but they sure as hell hope that you will get it and figure it out and help them work with them and develop that with them. So that's really important. The engagement piece, I think, is another one that we talk about. Yeah.
We have a contract that just went live in July with Perform Care for family-based mental health services, and that is the outcome measure that's actually.
Say it again, I'm sorry?
That is the measure, that is the outcome measure that's actually.
Right.
Yeah.
Are they looking at like kind of 10 visits per year, or are they looking at, you know,
Well, so they've got 3 tiers, and they're paying us fee for service, and then I think it's 6 months is the full length of stay. So if you stay 2 months, they're going to reconcile
Yeah.
based on $4,000. If you stay 4 months, reconcile based on $7,000. If you stay the full 6 months, then you get the 10,000.
okay, so, all right, so, oh, that's good, so,
Yeah.
unlike they used to do.
I just want to question there, when you're talking about engagement, if they would move to a different level of care, you still get credit or what?
No, once they discharge from our program, then they mark that as a point in time, and they'll reconcile based on where you fall in that.
Yeah.
So their expectation is for them to be there for the 32 weeks, because then they figure that that's more successful coming up to 32 weeks.
I'm not certain of that, because if you look at the break points, if the differential between the first and the second and third, I'm not sure. I'm not sure
So
what
it's
they're.
probably 6 or more.
Yeah, it
It's
certainly,
6 or
you
more.
start to see much bigger benefit financially if you stay into the second one.
And did they calculate then their rate, and then they came up with that amount?
Yeah. Yeah,
That's
they took past data and put that into what the average number of services were.
So when they made you that offer, or they came to you with that arrangement, I'm assuming they initiated the conversation? Okay. So how did you evaluate whether or not that was a good deal for you, or whether it was feasible for you to do it for the amount of money they were offering, and how did you look at that?
So we kind of looked at that, how many visits will this pay for, and how often do we exceed that, how often are we under that?
That's great. All right, so that's a good example of you did have sufficient performance and utilization data of your own to look at and say, does this offer they're making us make sense? Do we think we can achieve it for the cost, the price they're giving us? Absolutely.
You did the utilization rather than your staff and your administrative cost. What did it cost you?
We did it less on the cost and just looked at what current reimbursement is and what's the new reimbursement.
Okay. So you were going to do better than you were doing was the key. Okay, so that's one definite way to evaluate. And but I also appreciate your point, which is to say to really understand your true costs for doing it. Right. And probably you're going to end up getting somewhere in the middle there, right? But knowing that for your negotiation is important.
Yeah.
Sure.
And that's a program that we're historically profitable with, so to me it was less of an issue versus some that we've got shortfall in. This is our way to close that gap.
Sure. That makes sense. Absolutely.
Now, our NCO that we based doing dashboards now, where they're seeing the dashboards, us on a quarterly basis as to whether we're going to be preferred or choice.
So
So
they're ranking you according to certain quality measures, and they're going to put you in a different category or a tier, and your reimbursement's going to be based on what tier you achieve. Yep, that's another standard. So what are those quality measures right now that you have to achieve?
Is how often they're being seen, and each, there's 9 quality measures, there's 9 measures. There's 6 that we could control and follow, but then there's 3 that is going to be just claims-based in order to do that. How many hospitalizations, the number of days, that piece in there, whether they go into RTF.
But that still goes to your performance, whether or not you
Yes.
achieve those. So how do you evaluate your own performance against those measures?
And that's what we're trying to figure out now. We're working with our IT department to come up with a dashboard for ourselves. We could look at, if somebody's in the hospital,
Sure.
how long, but
Do you get alerts when somebody you're serving goes into the hospital?
It may be a couple, maybe a week, so we're not needing that 48 hours or 72
Yeah,
hours.
okay.
And that's engagement with the families. But they're starting it with the family base because I think that's the easier one for them.
Is anybody getting real-time alerts on ADTs, admission, discharge, transfer, anything from hospitals, from others? Are you?
We have a phone line direct everything with the hospital because we have to be taking all these measures. Every time anybody uses the ER, and we're communicated, we send our navigator over, we connect with them and work together. And so we try to have to reduce, your ER admissions.
Yeah.
I know in the first quarter, the first year that we were engaged in the clinic, we had a 20% reduction in the hospitalizations, which was really.
That's huge.
That's huge, yes. And the engagement, because we have the opportunity to be able to use a whole team of staff, for the initial engagement, we have open access, and we've implemented that model. And in that way, the person that when they come in, they may have to wait, but we'll have a peer to engage with them. We have a care coordinator, case managers, and whatever is necessary, because what we wanted to see is after the intake, that first time that person comes in, what percentage of those folks are coming back for the next appointment,
Yes.
which is the first actual scheduled appointment.
Right.
And that has, we've seen a significant difference there, in reduction in what we call our no-show,
Mhm.
which is another measurement that we keep tabs on and report to the state. There's a whole bunch of measures.
Sure. Can I ask, when you see the individual with a care manager, or do you use peers or others who are non-clinical staff, does that count towards your measure of being able of seeing someone, or no?
Yes.
It does. Okay, good.
The way we do it is with per diem, rate per diem per client, we're in a whole different
Right.
system. So whatever services we put in there, it all gets rolled up into one rate, and all those notes have to be validated, because that's what we're doing right now is validation. We submitted all our data for the first year now. We completed 1 year of this whole new model, and then they come in and look at all our charts to make sure that what we're saying really all happens.
Sure.
It's
So do you know how you've performed for the year, even though you haven't heard back from them?
We've had some improvements. It has not. The first year was very difficult for a whole host of reasons. The rollout was incredible. We also were rolling out a new EHR system at the same time, because the data collection is incredible. So we had to use two systems in any event. It was a real struggle. So first, so we're not sure how accurate. We could have been doing even better than what we thought, because
Sure.
obviously we had to go back to the charts.
So there's a couple lessons learned from that I'm hearing very clearly.
We have to get an extremely robust EHR system.
Yep.
In order to do the data, and not only just do the data, it took forever to figure out where you have to put the data in the charts. So that
Yes.
it can be pulled to get the
Yes.
report that you want, and then to do the analysis that it's nothing but.
So, yeah, please.
So are you getting paid per member per month at this
Yeah.
point? Okay. And then in terms of, like you said, that you get a call from the emergency room if somebody comes
We
in?
have very close care coordination agreements with our collaborators within the community, particularly the hospitals. And then we have some, what we call DCO, designated collaborating organizations. We have two, which we pay them to provide the services for our clients, like crisis, and then also.
Oh, you're a CCBHC.
CBAC.
Ah, now the light bulb goes off. I'm like,
I didn't know if she had said that earlier.
This is
Yeah.
yeah. But this is the way it's all going.
Right, right, right,
because
right.
Yeah, it
this
is.
The way it is.
Yep.
But for the person who goes into the emergency room,
Yeah.
is that it's really it's the responsibility of like whoever's doing intake at the emergency department to ask the question? Or is it the person's job? I mean, I guess that's the whole thing.
Right.
How many people do you?
right, how do you get your alerts?
Because of somebody didn't ask the right question, or somebody chose not to give the right answer?
You mean from the hospital?
Well, from both, in terms of the person who's registered with your agency, who goes into the emergency room.
How does the hospital know is
How
what
does the
you're
hospital
asking.
know, in the sense that, well, if they ask, I
Yes.
Well, either we're
Self-report.
gonna find out way later, we're not gonna find out
Right.
if that particular person does not say, well, I'm
Okay.
a over on the outpatient program there, until much later, because we wanna know what happened, and then we have case managers who pursue if the client doesn't keep the,
I got,
Yeah.
they go follow what happened to.
But it's self-report is what I'm hearing.
Yeah, because that is, when we were talking about the family base, those three with the claims. If the family doesn't say, we have other services with such and such,
Right.
we're not notified.
I understand.
My suggestion has always been is, the NCO is
Yes.
made aware of that.
Yeah.
So that if the family comes, that maybe what we could do is sign a release stating that if they go into a hospital or whatever, they can sign a release from the NCO to contact us.
Yeah.
I think that would be the easier way.
Makes sense.
but I'm just curious, because I don't know what the phrase is or the term, but isn't there's the health, kind of system.
The
where-
exchanges?
The exchange, thank
The
you.
health, so they're all different acronyms, but well, you're talking about health information exchange, where if you sign up and you're putting data in, then theoretically you can get flags out. And every one of these is in a different stage of evolution in every state, unfortunately.
It's not in,
So the problem is it takes critical mass, but eventually there are EHRs that are building out the capacity to accept those flags, those alerts, and then having those systems, those interfaces and exchanges. So if you haven't already pressed your EHR vendor about this, I would have a conversation with them and say, where are you on building those interfaces, connecting through these health exchanges, and making sure that you're getting data on our folks. How do we get those flags and notifications? MCOs are another option. In some cases, when the MCO gets the notification, if they already are aware, they can push it back to you.
When you're saying
Absolutely.
Our ER system, so in other words, if we go with the ER system, we should be talking to them as to where they are with, say, Pennsylvania with
Right.
the exchange.
Yes, correct.
Yes.
And when you're saying the exchange, so the hospital or somebody has to be involved in that
Right.
exchange.
Sure.
Right.
For us to
They would have
receive
signed up.
the
Yes.
information.
Yes.
It's not the family signing
Right.
up.
No.
No,
It's
the provider.
hospital
No.
signing up.
But then there is information then that has to go in a consent that the person has to understand that their information will be exchanged. Yeah. So yeah.
That in one of the other states I recently worked in, the providers, when Cindy was talking about preferred versus regular, that what that meant in that context was those providers were moved to the top of the list from a consumer choice
Yes.
perspective.
Yeah.
So that, and so one of the payouts or one of the benefits was that you ended up with a larger base.
Mm-hmm.
Can you at some time during the talk today talk about how that is done? Because I think we are very focused on cost and quality.
Mhm.
We forget to negotiate for volume.
Sure, absolutely. Well, so that's a great point. And usually one begets the other. So usually if you're, like was demonstrated here, if you're achieving outcomes, quality outcomes, then you may get bumped up the list on a network and the MCO or payer will increase their referral rate to you. And so it sort of begets, they have preferred providers for certain things. They'll look at your quality measures and say, we're going to direct more referral traffic to you. Absolutely. And that can be, there's all different ways to do it. They have to have some sort of standardized policy. It has to be transparent generally. They can't just, because otherwise it's like a free-for-all and then you get into issues, all kinds of legal issues with, preferential treatment to providers if you don't have a clearly established set of standard and some transparent policy and process about how you're doing that. So they do need to have that. So if you don't know, so individual plans, if there isn't, there's a couple big ones that everybody knows about, right? You've got your Medicare, like Star Advantage programs and things where there's big standardized quality measures, but each plan may have their own policy on that, and you would want to understand if you're in contract with that plan what their policy is for putting you at the top of that list, and they have to share that with you.
Are folks here familiar with the Pennsylvania eHealth Partnership, which is what we're talking about? Pennsylvania actually passed a law in 2016 to establish this kind of health information exchange that we're talking about, you really should get yourself familiar with it, because it's in every county is participating in them. And it's called the Pennsylvania eHealth Partnership. So take a look at that and make sure that you're getting connected into that. Are you?
I'm somewhat familiar, but I know there was a lot of complications, and that's why we didn't use it. I forget what it was, but it wasn't that simple.
And
We have
they're
a question
evolving.
back here.
They are evolving.
Well, maybe more of a comment than a question, but the HIEs, I think for small community-based providers, there's a daunting challenge.
Yes.
For those who might be
Yep.
prospective. Most of them, I know these in West Pennsylvania or maybe nationally, are tied into large healthcare consortiums.
Yes.
Right.
Without mentioning any names. And those healthcare, they also happen to own providers that they
That's right.
Sure.
and so I think the exchanges have been a big challenge, at least in our part of the state, to try to play through that. First is cost, and second is who's controlling the exchange.
So-
But we do need it. We need to be able to see information,
Yes.
because most of our folks are being served by 2 or 3 different
Yep.
organizations. Nobody knows the others.
Exactly.
That's the biggest shortcoming when it comes to a continuum of care.
Yes, I agree. I just wanted to respond to his comment, if that's all right, and then we'll go right to you, which is that, so this is, and I don't want to sound like a broken record, but one of the things we highlight as a potential benefit for partnering with other providers is the notion that you can do shared purchasing arrangements. So for prohibitive costs, infrastructure, cost of doing business, things increasing like HIE, HIT, these sort of large expenses to remain competitive in the industry. This is something where if you get 5, 7, 10 providers together and you select something together and then pool your resources and do some shared purchasing, there are ways to do that are totally legal, that are not antitrust, that are, and then that helps to disseminate those costs across a broader network, which is one of the reasons we do espouse as a particular strategy for smaller providers. If you're not in a place where you're, partnering with a large health system, or if you're not, contemplating consolidation or merger with your colleagues, if you're not, a tool for doing this is those networks and coming together through some shared service arrangement and being able to purchase those things and defray costs across a couple of providers. You can usually get some economies of scale, cost efficiencies with vendors for that stuff, and it helps you to do some of those things that might otherwise be prohibitive. Sorry.
So what I just wanted to ask is about
Please.
this Pennsylvania eHealth Partnership. First of all, is that, in terms of the cost of that, is that like something that is much more reasonable than an HIE?
HIEs feed into it. It's a health information, sort of a broad brush stroke organization. There are 4 of them in Pennsylvania.
Okay.
4 HIOs in Pennsylvania at this point. I think there might be one more coming on board. But it's now operated by the Department of Human Services. They are the ones that are actually sponsoring the eHealth partnership. And so you'd have to look on there.
So
It's essentially a hub.
Yeah, it's a hub, right?
Yeah.
for the
It's a net.
secretary?
Sure, if they have, I think you could ask them what their strategy is for making sure that community and behavioral health providers have access to the health information exchanges, and what kind of things the state may do to help facilitate that, whether it be subsidizing expenses or other things, or putting out grants. I mean, there have been tons of federal and state grants all over trying to help providers of every shape and size get connected and get more efficient use of HIT, so they may be willing to talk about that, absolutely.
And on the DHS website, there is a provider toolkit that you might find useful. And to Meggan's point about kind of coming together as a consortium of providers, I think that toolkit could help you decide whether or not how you pursue it.
So we have some tools we can also share that are just sort of free, that we've compiled, that we are resources for folks around measures, around what are the standard measures. We can share some of the materials from the National Quality Forum on what Jen was mentioning around home and community-based services. Does everybody here have some kind of dashboard or business intelligence tool that share, that you pull information from to inform your management of your agency and services. Because we have a whole bunch of information in here on the effective use of dashboards that I'm not going to dwell on a ton if you're using it already and you feel like you're doing a good job of it. Does everybody love their dashboard?
Yeah, does anybody want to see any of the information we have on
I mean, you
dashboards?
can get these, but, okay, all right.
PowerPoint by any chance
Yes,
will be available?
yes,
Yes.
yes. Every slide of it, because we're jumping around a little bit to be responsive to the priorities of the group. So every slide will be, and we will be available to you for follow-up questions. But so this is where we start. We start with literally the whole universe of measures, and I mean there's a long list of measures out there, and they have been affiliated and associated with different sets of measures. And then we talk with providers about, okay, well, you know, you've got a lot of different masters that you serve, right? You've got your clients, your consumers, who are, you know, hopefully the most important master that you serve. Then your team, meaning within your agency, aligned with your mission and vision and strategy for your agency of what you're trying to do for those folks. And then, of course, the people who pay you. And where you can identify alignment. If there's something that appeals to all three of those groups, then that's the thing you should be looking at every single day. And that's sort of where we start. And then you can add to that or delete it. We also encourage folks to pick a few, especially now before it's in a contractual relationship where you're getting paid or not paid based on it, and really put your full strength of your organization behind it and push and pull. And so these are things that we can look at. Do you want to, here, let me see. Did I skip past the dashboard stuff? So focus on anything you're already collecting that's feasible and usable. Here we go, dashboard. Do you want to jump in here? Is this all right?
No,
Here,
yeah,
this is all right?
yeah.
A good place to pick up?
So we talked about the need for a solid dashboard, and that dashboard not only has your baseline, but it also is demonstrating what your performance is. So you as a provider, your board, Meggan talked about, you know, your readiness as an organization. You really do need to assess the necessary capability that you have for doing a dashboard that's meaningful to your organization. Also, then you need to determine the source of the needed data. So what is the data that you need to collect in order to populate that dashboard, in order to make it meaningful to you, both on managing your population, the people that you work with on an individual basis, but then it's sort of an overall picture on your performance with everybody that you serve. You need to develop a data warehouse, and we were talking earlier about the potential to coordinate with other organizations. That data warehouse can really become something very robust through that kind of collaboration. And then you need to identify accountable staff for ongoing maintenance. This is really, really important. If your dashboard is going to be something that you use every day, you're going to need to identify the staff that's going to be taking care of it and managing it and doing the back end management of it. Because if you don't take care of it, it becomes really messy and unuseful. So it's really important.
We also say don't collect anything you're not using. If you're collecting data and you're not actively using it to improve and oversee your services, then stop. It's a liability. It's a cost. Every data point has a cost associated with it. Every data point has a risk associated with it. Don't collect stuff you're not using. And this is really, really tied to your partnership strategy, because data is a commodity, especially in a world where you have to demonstrate your value and your outcomes. And there are people out there who have data that you need and want, and people out there who want some of the data that you have and you need, right, or you collect. Think about what those symbiotic relationships look like to exchange that data, and there are ways to do it in a safe, protective, secure way that's, you know, protecting the rights and privacy of your clients without giving that up. You can do it. It just needs some thoughtful, careful protection and consents involved, but you can work with to look at, especially with other healthcare providers. So those are the 2 cents. Or
Just on that slide that we just showed, does anybody have experience with doing this and going through this process that you want to share with the group? No? All right. Then the next slide. You need to create a prototype and refine. This thing is not going to be perfect right out of the gate. It's going to be refined over time, and you're going to need to be paying attention to its evolution. As you develop those relationships, I think this is really going to be important for you to be paying attention to. Developing a mock-up or a prototype of the dashboard is a really important first step. So you need to be thinking about what information do I want to collect, and what is meaningful to me as an organization. You need to establish those data feeds, the interfaces with the data sources, so you need to figure that out. And then you need to get feedback from key stakeholders. Who's going to be using the dashboard? And we recommend that everybody uses the dashboard, that it doesn't just sit over here in quality, for example. It isn't just something that sits out there and somebody's responsible for it and then it doesn't get. So when we say everybody, your board needs to be using the dashboard. All your staff need to be looking at the dashboard. Your executive leadership, and the dashboards may feed different information to each of those different levels of individuals that are involved in your organization. But it's really critical that everybody use the dashboard in some way. And then, again, refining the dashboard. It works now, but in a year from now, as you've negotiated a different contract, you just negotiated that other contract. So what is the impact on your dashboard because of this new way of doing business?
The other thing is just make it super duper easy to use. You may be savvy about data. Not everybody in the organization will be. If it's too complicated, people will not pay attention to it. Any barrier. So do things like bars, lines that you can clearly see going up or down. Red and green and yellow are my favorites. Make it flash blinky lights at you if you have to pay attention to it. Make it pop up every morning when you log onto your computer so you can't ignore it. There are all kinds of tricks here to sort of make sure that you're looking at the things that you need to. Make it so easy and user-friendly as you possibly can. It's the only way you'll get really persistent use.
And along with that, train people on these dashboards. Give them the information they need to value the dashboard and be looking at it every morning. It pings them. They look at it and we've got an issue here. We're going to have to address this today. Right. That kind of thing. So I think training and technical assistance to people so that if they're not data-friendly people, they kind of are afraid of it, that they get comfortable with it. And you can help them evolve.
And it needs to be a part of supervision every week. It needs to be, if you're using it, if you're including it in performance and employee evaluations, if you're bringing it with you, if you're asking about it on a regular basis, then they will have no choice but to pay attention and really actually look to it and manage it. So you can make it that way. We just have some examples, different ones in here. We literally, and you do not need a big flashy piece of technology to do this. We did a bunch of these real quick mock-ups on Excel. You can do things very basically for a lower cost and pull, as long as you have the source data somewhere. So the expense and the investment should actually go in making sure the source data is good and clean and that it can be pulled easily into a system. The dashboard itself is not the big expense. There's lots and lots of flashy tools out there. Most EHRs now have some kind of business intelligence piece attached to it, like a Tableau that'll just pull out of your record and make it look pretty for you. Just make sure that it's worth taking the time to make sure it's set up in a user-friendly way. But beyond that, you do not need some big, new, additional, expensive piece of software to do a good dashboard. All right. So we talked about a couple of the domains. I want to spend a minute or two on the financial piece of this because there's a financial operational measurement component that I think is somewhat new for some people in our industry that we want to get into. And that's really about sort of how do you look at your costs in a different way than maybe you've had to historically. The very first thing I tell people is your costs are not anywhere related to what you're getting paid right now. Which you all realize, I guess, right? Right. But the issues of sort of what does it cost mean something different in a value-based world, right? Do you know where Do you know what the cost of the next service is that you're going to deliver? Do you know what the cost of the next person that you're going to serve is? And do you know about how much it costs you to get to that outcome? So I made up the supported employment example, for instance. But if, in fact, what you're doing is saying, I have a supported employment program, and what I do is I get people jobs and help them keep them, and in turn, that makes their health outcomes better. You have to know how much it costs you for every job you're getting, right? Which is not the same. If most people, 50, maybe 60% placement rate for a supported employment program if you're doing pretty well. And then how many of those, you've got to know how many of those are still have the job 3 months later, 6 months later, 12 months later, right? And so what you need to do is then start to break down and really look at, well, here are my costs for the program. So what does that mean? What does it cost me per job placement? And then per retention 6 months later, and then be able to really look at what do I need to get paid for those milestones in order to get my return on investment, so I'm not out money out those costs. And so being able to slice and dice and look at your unit costs and your marginal costs and the cost of the next job placement, the next outcome that you achieve is part of this. And so how many people are looking at costs in that way that you can sort of say, here's what I would need at bare minimum to break even, and then I better negotiate a 10% over that because I know that there's always going to be unpredictable costs and things I haven't thought of and startup costs and other things. And then I have my risk level, right? If I don't want to, what happens if I have a rough year? I want to make sure I build in a little cushion for myself. So looking at things like that, when you think about the cost side, because we frequently are, the payers come to us in healthcare, right, and say this is how much we're going to pay, or they offer you a rate, right? One backwards industry, but that's what we do for frequently. And so how many of you have had an opportunity to look at your costs and go to a payer and say, here's what I need to be paid or reimbursed for this service to cover my costs? You have a PPS rate through the CCBHC, so that's, yes, that's, so you have to develop your cost report and all of that and allocate those. We could have an interesting debate on the PPS rate versus the value-based payment structure and what the tension is there. CMS is going to have to wrangle with that one soon. So just cost structure, I mean, have you looked at, when you look at your own, have you ever looked at your own cost structure? Who's ever looked at your costs and said, oh man, we've got to reduce our costs. We've got to become more cost efficient for this service. It's costing us too much per person served or per outcome or per. Everybody's done that, I hope, at some point, right? I mean, we're pretty lean and mean as a system, but there's occasionally inefficiencies we can find and trim and save money, right? So, so when you do that, how do you approach that? How do you get at reducing cost inefficiencies? How do you look at your costs? Go ahead.
Well, I think it's interesting because you mentioned lean and mean, and I think it's misguided to say, how do we reduce costs? I think it's how do we get more services? How do we get more services?
Okay. It's a good framing.
That's the way that I encourage our folks is
Mm-hmm.
if it's 2 visits a week, but the person can make do with 1 visit a week, that opens you up to add another client to your case.
Sure.
So
That's great.
Cost per individual service.
Right. That's great. That's a good example. So that's about sort of reinvesting any cost savings you do have in additional services. Absolutely. And yeah.
As was mentioned earlier, it's doing business a different way.
Mm-hmm.
It's no longer being focused on how many units I'm producing each week, but maybe how many folks am I serving on my case.
Sure. Well, and that we heard about no-shows earlier, right? One of you, there's sort of, it's 2 sides of the same coin. You can either frame it as reducing your costs, or you can frame it as increasing your revenue per unit because you're increasing productivity, right? So how many of you have incentive programs for productivity for your direct care staff? Okay. Has it worked? Has it increased your productivity? Yeah? Okay.
Well, yes, but
Go ahead.
it's more units, but not necessarily more individual served. We don't know. In this model, I don't know if we can hire quality out people. I don't know if we're serving more individuals.
Okay.
But I think there's an interesting transition here. So how do we move from that model where I need to produce 32 hours a week to maybe I need to back off in order to
Sure.
have more folks in my caseload?
Sure. Right. So the constant balance between individualized, making sure the services are responsive to what the individual needs, and achieving those quality outcomes. So there's only a couple ways to get there, right? Which is to have that data to know, to be able to look at then. So how many people have looked at quality outcomes according to 30-minute visits versus 45-minute visits, or by individual provider, or those are the kinds of things of really understanding what it is, what are the characteristics that are driving the quality outcomes, right? Is there a difference in quality between a clinician who has a 28-person caseload versus a 40-person caseload? We assume some of those things, right? We assume that lower caseload means higher quality. But to really know, we'd have to look at the data, because it might just be the clinician, right? So those are the kinds of things, just having those systems in place to be able to look at, and be able to look at by, direct care worker, by all kinds of things. I've looked at no-show rates with clinics and other clients by day of the week, by time of day, by slicing and trying to get at everything you can. And a lot of what we've learned is it is a huge clinician or provider behavior is the single biggest predictor of no-show rates. And there's a whole bunch of interventions and things that they can do. But in order to negotiate anything, a value-based payment arrangement, these are the things you have to know about your services. You have to be able to look at them in every possible way and ask the question, what's driving my quality outcomes? What's driving my costs, and what's driving my revenue, right? And so those are the things. And if you can do that and combine the financial and the quality piece, that's it. That's the value-based payment equation in a nutshell. Sorry, there's a question?
And this is probably way off track of what you're talking about, but it's coming to mind as you're talking. You had talked earlier about knowing who we're looking to partner with, who's going to pay us to do something.
Yes.
And I'm thinking back to your original discussion of New York State giving billions to hospital systems and
Yes.
behavioral health systems.
Yes.
Which makes
Mm-hmm.
sense. And hearing you say the metrics and where we're saving and whatever, in any of the cases in New York State, did the hospital systems pay behavioral health providers directly as the way to?
Yes.
Did they do a bundle rate and then pay the behavioral health?
Yeah, that's a great question. So they did, and so some of that was because they were pushed to. There was actually a huge media attack on the hospitals for not pushing out funds to community providers at all. And so they were sort of shamed into doing it and had to build all these networks and advisory boards and things and then now I'll tell you what they started to pay for. They started to pay for integrated care, right? They started to pay for behavioral health providers in the community to come in and do on-site integrated care, collaborative care models, those sorts of things. They did pay for diversion. They started to pay for diversion models for those who were able to come and, send a patient navigator to an ED or do our peer support access so that you were diverting folks. There are a couple of different things they did, and they're still figuring out how to do that. There's this huge question, right? Somebody asked build versus buy. Right? How do we convince the healthcare system to buy what we're selling versus to build it themselves? Right? Because I have friends who are hospital executives. Most of them are really nice people, and they're trying to figure out how to achieve all of their metrics and their goals and to take on risk and do all of this. And they know that there are gaps in what the folks they're serving are getting. And so their instinct is going to be, I'm going to figure out how to do it myself. Because sometimes that seems easier than negotiating a relationship with you. And I don't really understand what you do. And, and we don't really speak the same language, or we have very different cultures and all of that. And so the issue is I highly encourage you to be making those overtures to say, listen, here's the value that we're providing for the people we're serving. I think, I think you need me. And the thing is, if they have to believe that you can do it cheaper and better than they do it, right, in order to be interested in talking to you and buying it from you. Otherwise, they're just going to build it themselves, We have FQHCs that are building food pantries because they're saying, I can't keep my diabetes metrics aligned. I can't produce my quality outcomes on diabetes because the people that I'm serving are living in a food desert in the South Bronx and they can't get access to healthy food. So how in the world are they going to control their A1C3, right? And so so what's the answer? The answer is I'm going to get them healthy food because that's going to help me get their A1C3 levels under control, and then I'll meet my quality measures and get my quality bonus payment. And so the issue is if they have that need, then how do you fill that need? And that just comes back to the healthcare system as a new client for you and thinking about what value add you bring to them. And they may think that they can do counseling and treatment up to a certain degree. I don't think most healthcare systems want to be in the business of peer support and supported housing and, rehabilitative psychosocial rehab and those sorts of things. I just don't think they know how to do that. The home and community-based service thing, we have the data that says that home and community-based services keep people out of hospitals. So I don't think they want to get in that business. I don't know.
I agree. I think that's where you're really in the driver's seat, and you need to be able to say, this is what I do well, this is what I know how to do, and your health system, you don't really notice space. So, did you have a comment?
Yeah, I was going to say, just to your point, it's interesting because one of the things that we're doing now is bringing pharmacy right in with us because in order for us to come out with good
That's another example.
metrics on medication compliance, it works a lot better when we got them right on site and we can work together with the pharmacist and with the medications right there. And they're catching on to that, so now we're getting a program, well, we can expand it, and we can do more, and we'll work with you, because then they look good, and of course, then they're selling their product, so it works
That's a great
hand in
example.
hand. They're getting the business, we're getting the metrics, and the clients are getting the benefit of better medication compliance, and so it's just interesting, but that's taking place in our field.
Yeah. Yeah. So one of the things that's happening is community-based organizations, and not just in New York, it's all over. This is happening in Michigan, it's happening in Seattle, it's happening, or Washington State has a big push right now on it. There's a whole lot of different places that are looking at this. And so the CBOs, it's a little backwards because the infrastructure and the resources are going to be with the big systems, but they have no incentive to necessarily go out and find and partner and understand and interact with agency by agency by agency. Even the big behavioral health agencies, they don't necessarily know where to start or what to do. So you kind of have to go to them. And so a lot of what we're seeing and hearing working are community-based organizations coming together in networks also to say, you know what, for this community, we can meet all of those, we have a food pantry in our network, we have a housing provider in our network, we have all of these different services. So you have folks who have these needs, let us take care of them because what they want is an easy, efficient solution to their problems. They know that when someone walks out of their ED or inpatient unit, they don't have these connections, but it's a lot of work for them to figure out who in the community do I partner with and how do I build that network. If they have one place to go, a one-stop shop for the community-based services in their area, and then they could hand you a sub-capitation of their rate and say, you're going to manage all this other stuff for me, great. Then they would love to do that for the most part. That one-to-one interface is going to be a big, so that's just another argument for partnering, is administrative simplicity with interface for your customers that you're now marketing your outcomes and your services to. All right, so we jumped all over this. I'm going to just take a second. If there's somewhere you want me to go, Jen, and I want to make sure we've answered all the questions that you have. Somebody had a question earlier about credentialing and the commercial side of the, I'm sorry, was that you? Did you have one? Somebody did. Did you have a question on the commercial side?
No, I think that might have been me. I was asking about measures and how they relate across Medicare and Medicaid.
Yeah. So on the commercial side, mostly what you hear is employers are defining that, right? So more and more employers are getting involved in driving the outcomes on the commercial side. And my primary expertise is on the Medicare and Medicaid side, so I don't claim to know a lot about the commercial side. We have other people I could connect you with who could probably answer that a little better. Again, the folks I've spoken to are at the managed care executive level who tend to operate all of the above, commercial, Medicare, Medicaid, whatever. And it's not that the outcomes differ that dramatically. The focus is far more because you tend to be on the commercial side on definitely engagement, definitely meaning length of stay or dose, response for going to more than one appointment. So completing a whole episode of care, right? Things like physical therapy or follow-up or those sorts of things to make sure that when something acute happens, someone is going through the whole prescribed process of care for them. And that's going to get you more. Commercial side is going to, I think, push more and more into those bundled payment arrangements because of that, because it's less about managing long-term chronic health care issues and more about acute care episodes and follow-up. But that's sort of the extent of my insight into the difference between the commercial and the public side on that. Okay, so I'm going to recap a little bit and then just make sure we don't have any other questions. So the recap, so we talk about a readiness assessment that we do. We work with providers and payers to do a readiness assessment. And so I'm going to go back to sort of the domains of that assessment, right? So looking first at organizational readiness. This is really at your level, the board level, and knowing and sort of gauging and having a clear sense of your staff's readiness for change and understanding and ability to appreciate the paradigm shift and what it means for them. We frequently find that what that does is meaning connect it to care, make it about more tools and more resources for them to do what they do better, arming them with data in a not scary way with nice blinky green and red and yellow lights that tell them where to look and what to do and help them just make their lives easier, not more complicated. About maybe driving incentives to your direct care workers in order to, when they achieve those outcomes, to help make sure they're getting rewarded for it, whether it be monetary or otherwise. But really looking at tools like that to help them. And to the no-show rate, this is, I take no credit for this because I heard it from a clinician that I worked with that, who said that the way that she ran an outpatient mental health clinic, and so the way she framed her approach to improving productivity at her clinic was about every missed visit was 2 people not served, 2 kids not served, 2 people not served who needed that service. It's the person who didn't show up and the person who could have had the appointment or the slot if you had known and if you had and all of a sudden clinicians want that to go down. You don't want, and you're sitting there during that hour. I mean, yeah, you might catch up on some paperwork and stuff, and sometimes clinicians like that little respite, but every one of those thoughts is 2 people who aren't served. I mean, you feel some different connection to the work, and the productivity becomes not just about, can I cover my costs sufficiently, or did I get the revenue for that slot that I needed? But there's so many. I don't know of anybody who thinks every single person out there who needs outpatient mental health treatment is getting it, so we're good. There's way more demand than is being, and so for me that really helped, because I think frequently clinicians feel like the burden of an increasingly complex financial system is more and more demand on them with less and less empathy for how difficult it can be, and just helping them to streamline what they do. Get rid of anything you can get rid of, make the EHR tool that helps them. That can be a really big deal. The second domain is partnerships. Who else is serving the people that I serve? And I'm going to go back to these slides that sort of captured this in the beginning because it's probably easier for you if you see it. So partnership readiness, who else is serving it? And this is everyone up and down the spectrum, but knowing and recognizing where your clients are getting their primary care, who is helping you to achieve outcomes, and collaboration and data sharing opportunities. Care delivery and HIT going hand in hand in hand. Just addressing things like quality improvement and data monitoring, alerts, registries. We didn't really get into population health management that much. Everybody's probably sick of hearing about that too, right? You're all doing it in some way. That's why I don't dwell on it too much in a crowd of behavioral health and long-term care providers, because by nature of what you do, you know who your highest risk folks are. You're doing it maybe maybe a little more instinctually than analytically in some cases, but you're putting people in risk groups, you're making determinations about how frequently they need to be seen. That's what population health management is doing regular assessments to know and map that to what people need and making sure you're not just giving the same prescription or same service to every single person. And also recognizing that sometimes the intervention that helps keep people healthy is actually not about treatment at all, right? That's the other piece of population health management. My favorite one was we had a rash of heat-related deaths. A couple of years ago, we had some pretty bad heat waves and in our programs and some of the mental health programs that I was overseeing, and we looked at the data. And so the next time we had a warning that it was going to hit 100 degrees, we got all of our case management programs to do an air condition check, and we itemized and created a registry of everybody on psychotropic medications who were going to have that effect, right? Where the heat was going to be a bigger issue for them. And then everybody went out and did air condition checks. And we bought about 17 air conditions for people in that heat wave. And it might just be a coincidence we had no deaths of people living in mental health programming at that time. And so it wasn't that they needed a mental health intervention at that moment. They needed an air condition that worked. And so these are strategies when you can sort of, a population health is to say if you have in your record a list of everybody on psychotropic medications who's going to have that issue, with regulation, with, thermoregulation, that's related to their medication, just know who those people are and do a double check on them and see if they need an air condition. And could most states have programs where you get cheap ACs for people on public benefits, right? And you can figure something out. And so there are things that you can do that are, and overall, that's relatively low cost compared to a lot of other interventions that you might have to deal with. So these are the kinds of things, making sure that you all know this, client-centered care, integrated care, cultural and linguistic competency, things that the healthcare system could learn a lot from behavioral health and long-term care providers on. Domain 4 is our financial and operational readiness that we talked about, really moving away from per visit to per procedure or per episode of care. This is increasingly complex when you're talking about behavioral health, because what does an episode of depression look like? That's a lot more complicated to define than a stroke or a knee replacement or a pregnancy or other time-limited sort of acute things that need an episode of care. But we're getting there. We're getting there at learning, and there are lots of very smart people looking at and determining how to define an episode of depression and how to define acute care needs for people with behavioral health issues. We talked about, there's your population health management pyramid. This is your complex care management. So the highest need people getting your highest, most complex care, and just really thinking. So at the broadest end of the pyramid, these are the healthiest people with the lowest risk, the least amount of chronic health issues and conditions. And the idea is just stopping bad things from happening, essentially, or being there to quickly respond when an acute issue occurs. And then you move up the pyramid for potential rising risk. And we always come back to the first commandment, which is know thy performance, always. These are the things that help you make sure that you are not, if you're taking on risk. And use a dashboard, use it well. We include questions about whether or not leadership is looking at a dashboard, what kind of quality data you're reporting to your board. Does that get shared in a meaningful way throughout the organization? So I would say that. And I think the last thing, I'll just go to some lessons learned. I'll just pause, make sure there's no questions that we haven't addressed. Anything?
Any questions that we haven't
I'm going to go
addressed
to our
that
list.
you asked early on?
Oh, I know what. We're going to do 2 minutes on this that we sort of glossed over. So we talked about the provider-led networks, but we didn't. Do you want to take a minute and talk a little more about the provider-led networks before we adjourn?
Yeah, sure. The first one says you're already doing it. So you have a great opportunity to impact the beneficiaries' health outcomes because you already are closest to the ground. That question that you asked at the beginning about I'm worried that they're going to put me out of business, you are already having a great impact on folks' lives. Integration and coordination, none of you are an island, and it really is sort of a change in approach that you need to be thinking about as we move into this new value-based purchasing, which is not going to go away. I think Meggan is exactly spot on. CMS is actually driving states through their negotiations on the waivers that they approve for home and community-based services. These 1115 waivers, all of those waivers are really putting in and requiring some level of value-based payments. So that's definitely not going away. Certain volume and size is necessary across which you can distribute risk. I love the way that this is written. Be big or seem big. You need to own how big you are, and you need to be able to articulate it as you're out talking with other providers and figuring out what the different roles are for each of you. Going back to that, no provider is an island. You really need to be thinking that way as we move forward. Mutual accountability for quality. No one is good at everything, and that is a really important thing to recognize. And quality oversight is something that you all will be working with each other to understand and to be able to drive performance on. And then leveraging. How will you leverage this value with payers, with your partners? It's really going to be critical for you to figure out what your leverage is and how you drive it. So those really are thoughts that we have about joining a provider-led network. Are any of you involved today in a provider-led entity or provider-led network? Okay, do you want to tell us a little bit about it?
Well,
IPN?
it's a more of an arrangement with 3 different nonprofits that are wholly owned subsidiaries by a partner corporation. And that corporation is like a managed service organization. Handles back office functions.
Sure.
And the 3 entities, all of their own separate 501c3s with their own boards of directors, but those boards report up to the main corporate board.
Absolutely. That's a good example. And so nobody's in an IPA or an ACO here in the room? So it really hasn't become, okay, that's okay. Because value-based payments, the more and more they push into the system, are likely to drive people to form these networks. So it may just take time. There's other pieces, we say be big or seem big, meaning you can be, if you're not big yourself, or you don't have enough volume of services across which to distribute the risk by joining with other partners, you can do that. There's one more piece which I say, or be unavoidable. Be the absolute best, or in some cases you might be the only person who does what you do, so that if a payer or a network or somebody needs what you do and wants the best outcomes, they have no choice but to do business with you. That's the other one, is to be unavoidable. And the way that you do that by producing the absolute, but you've got to prove it. There is no way in this, you've got to be able to prove that you have the highest quality.
Would you consider the DCOs that we have in the clinic as a provider-led in a way? Because you're
Sure.
contracting, we pay them under an agreement.
Absolutely.
And they have access into our, portal into our EHR. Of course, we've got all the liability. It's high risk.
Sure.
Because we're responsible for those clinicians and for all the service that
Yes.
they're doing then. And they're at a distance, so you really have to know who you're linking up with and who you're going to be in charge with, because if something goes awry and you're responsible, even though they're a separate entity completely. But in this sense, they're working for you.
So it's funny that you say that, because a colleague of mine, I can't take credit for this one, is providers for choosing a network or a system that you would be a partner with. Parameters and thinking about things like, it does matter that there's some kind of alignment of mission and vision and values, that they're committed to pursuing this with a compatible risk appetite to your own, or that it's complementary. If they're willing to take on more risk, but you're doing your piece of the puzzle, is there a way to balance that collaboratively? That you can manage a full sort of continuum of services, which is part of what the CCBHC is intended to get at. If you can't do it all yourself, working with others and contracting it out to other providers. And that any kind of, and this says sort of membership or ownership fees, because generally when provider-led networks are first formed, they try to generate some kind of investment or to capitalize on member contributions to get started. That's really about making sure you're getting value for anything you put in, that there's a clear structure for sharing value, and meaning that you get a say in how that money is used and governed, and whether it's buying shared services or investing in data and analytics or information sharing or other things, making sure that you're getting your return on investment. So you want to make sure, and obviously with the goal being that eventually you're achieving a level of volume that allows you to participate in one of these alternative payment methods. Yes.
Talk a little bit more about the continuum.
Yes.
We, and Jen's aware, we have like our CPA, we have a group of
Yeah.
life providers
Mm-hmm.
who are collaborating to try to contract with MCOs on the LTSS side.
Yeah.
So you have a group of PAS providers, a group of service coordinators, et cetera. How does the continuum matter for forming that kind of a relationship? I mean, the full coverage of what?
Yeah, that's a great question. So at the bare minimum, I would say looking at a population, sort of, and we tend to define, right, grouping our populations by diagnosis or need of some kind, right? So the bare minimum, if someone has a behavioral health need, that you can meet that behavioral health need within your network. Because a payer, if they're going to a network, they want to know that I'm getting the individual's behavioral health needs met by you. I don't have to go to 2 or 3 or 4 different places and sort out, okay, this one's, treatment, and this one's rehab, and this one's something else. And so the bare minimum, most payers or healthcare systems, that they're buying something from you, want to know that you can meet those needs of that population. And it's usually organized by population, because usually insurance products and reimbursement methods, that's how they're going to stratify everything that way, right? Because they're going to group people into risk categories and cost categories and needs. And so they're going to think about people like the IDD population or the behavioral health population or the long-term care population. That's just how they think about it, because when they do their actuarial analysis on costs and things, that's how they break people into groups frequently, right? So at the very least, they want to know they get those needs met. Now, I think beyond that, if you can make a more comprehensive network, if you can meet long-term care, behavioral health, the whole range of potential additional services beyond your traditional healthcare, and you have a more robust network to market that you can cover those needs, that's great too. I would just say at minimum, you don't want to fragment, a specialty area into more fragmented specialty areas.
Single one of our services, no matter where we are, behavioral health or physical health or even long-term service supports, we end up with housing issues, transportation
Yes.
issues,
Mhm.
home
They
modification
transcend.
issues,
Yep.
all of those things that are not defined services per se within Medicaid,
Right.
that paid service. Is it?
I think you can only make your network more attractive, more appealing, and negotiate better rates if you can offer a more comprehensive package to somebody, to a payer, to another network, to a system. What you need to do is, it's going to have to sort of be iterative and start with covering the most basic things, and then you begin to build on or add. And it's going to take time to figure out the question that was asked earlier of how do you then disseminate value or credit to people, right? For a lot of that stuff, you're going to keep paying fee for service. You're going to have rates, and you're just going to keep paying it the way you have paid it, with maybe some little bit of bonus payment for quality outcomes that are achieved. So when you first form a network, it's not going to be some big, beautiful, complex algorithm of capitated rate that then everybody gets a piece. Like, it's going to mostly, it's going to be incremental. It's going to still be largely fee-for-service based, where people are going to mostly get their expected revenue and cost made and quality benefits. And then only after time and things evolve when you've really been able to, achieve a certain level of analytic sophistication to be able to predict what are the interventions that are going to make the difference so that the resources and shared savings are going. In the beginning, I would suggest that any shared savings achieved by a network like that, at least for a while, get reinvested in the network to build out capacity to be able to support everybody in doing all the things they need to do, analytics and the health information systems and all of that, right? As opposed to and then building up that capacity once you really have that time and that data behind you to look at, that's the only way then you can figure out how to divvy it up any differently in the future.
Do you see beyond Pennsylvania the movement towards including into services that are allowed those other services traditionally, like you have the fee-for-service system, you have your billable services, a lot of the other ancillary things that go on in keeping a person healthy, those social determinants type things.
Yeah.
Now it's coming into the language. Do you see in things like in Pennsylvania with our CCBHC demonstrations, there are things that are built into the service delivery that they have greater flexibility, so they can do more that will truly meet the needs of the member or the consumer. Do you see that taking place more in any particular place in the country? Is there a state that's done it more effectively? Somebody to look at.
The states I could think of are still very early on, and they're like nobody has a huge track record of this yet. Washington State has been building their what they call community hub health. I'm never going to get the acronym right. I can share literature with you on it if you're interested. Where they're trying to really Colorado, who brought into but now Colorado did it, and now they're starting to silo things off again and split up their reimbursement method. So there are states who have tried some things. There isn't a ton of track record on this.
Pennsylvania, the whole prospective payment system that forces the cost accounting
Yes.
that you talked about earlier, that is typically not in the operational mindset.
Yeah.
To be able to bring all of those things that aren't necessarily service related.
Yeah.
Those indirect costs that are floating out there that many times the financial parts of the organization know about, but the operational side don't.
Yeah.
And they never get built into a cost calculation that truly defines what the cost of delivering services, so that when you're going to take on a new initiative, you know what the return is, you know what the risk factors are, whether it's actually going to be profitable or not.
Yeah. I mean, theoretically, the future of value-based payment arrangements in our world, in our sectors, looked like freedom to buy what needs to be bought for that individual or family so that you meet their needs as long as you achieve those quality measures and you figure out how to do it. And because mostly that's what we've been doing for a really long time, right? We keep people out of the hospital, home with their family, safe in the community by delivering long-term services and supports and behavioral health interventions. So I kind of think we intuitively, instinctively know how to do this. We've got to get better at measuring and managing and monitoring it quantitatively, and driving it with a little more analytic, firepower. But ultimately, for someone to say, and it really becomes like, we know how to serve these individuals or this population. So, how much, if I can offer you or commit to these outcomes, because I know I can keep 70% people, below this rate of fill in the blank, then, and then that's your negotiating leverage. And then if I'm a behavioral health provider, I want all those people on my team and my network, because I know that if I can't get somebody transportation to their clinic visit, then they're not going to come to their clinic, and then there go my measures. So I have a feeling, quite frankly, it's going to be less up to the plans. I don't see the plans total and the healthcare networks really figuring this out. I see them delegating it to our systems who already work together in some way on these issues and pull these supports together And so what we need to do is have the math, get the math right to figure out how much we're going to charge them to do it.
You know, managed care companies have said that, they put it off on the providers. You figure it out, come to us.
Yeah.
Right.
And that's very abstract thing.
Sure.
You know, and with other clients that I've worked with, I said, you know, do your own internal homework, calculate a case rate.
Yep.
For your people, know what your costs are to actually deliver. And there's a lot of pieces of the enterprise that don't get factored into that case rate.
Sure.
And if you can start building a history on that, then as you mentioned earlier, when you go in and have that dialogue with your managed care company,
Right.
you're armed.
Yeah.
Right.
They're going to be armed.
Right.
You have to be armed.
Right. Well, and I think so New York was one of the CCBHC demonstration states. And we had some big discussions with CMS at the time about, is it at odds with our very aggressive move to value-based payments? Because it's theoretically a cost-based reimbursement model, right? And so we certainly didn't want to derail CCBHCs, and we wanted behavioral health providers to get this cost-based reimbursement because it's fantastic, but then, so the state had to sort of go back and forth with CMS, and the issue of if you can produce the quality outcomes and if you can manage within that rate, and it's really good training for VBP arrangements theoretically. At some point, you're gonna have to figure out how to find cost efficiencies in there, because right now the game is to dump every cost you can possibly think of into that rate. Are they? Okay.
In fact, there could be more costs sitting there than what they allow.
Sure.
Everything has to be direct connected to the client. Administration never counts, you're out.
Sure.
All that indicated.
Mm-hmm.
But it's, you just have to do your formulas, right?
Yep.
And,
So I think that's good preparation, long-term, for value-based payment to really get your cost, a handle on your costs that way.
There's many in there as, there are direct service,
Yeah.
They were pretty open with, as long as they were,
Conceptually, it moves us in that direction that we have.
Yeah, agreed. It's a good question.
So just to clarify, as we move towards value-based, rather than fee-for-service, or even pay-for-performances on the front end, there's some specific things that currently Medicaid says Medicaid dollars cannot be used for
Sure.
these activities.
Mm-hmm.
Under value-based, as we start moving up the continuum,
Mm-hmm.
can they get rolled into those as part of the reimbursement? Or do they still have to be carved out as, because you can't use?
It's a great question. It's a great question. So that's going to be more up to the payers in the future in a value-based payment model, right? Because managed care companies in particular have funds that they call, where they use for alternatives. It's called in lieu of, or other mechanisms, right? Where they,
Value
yeah.
added and in lieu of.
Value added, and thank you. And yeah, so they're going to have more flexibility on what they buy from you, because it's like the Medicaid dollar gets washed and the Medicaid comes off of it. It's still green, but once it goes through, it goes in that capitated rate for the managed care company, because they have some flexibility in their funding and they have pots of money that are they can use for alternative things. They can buy something theoretically like housing, like a subsidy for housing that helps somebody get stably housed. You do need to be a little careful about how you are with it, but it's going to be really largely then on the payer, and then the payer passes those funds down to you and might give you the flexibility to buy things that historically you weren't able to buy with Medicaid dollars.
that would be if the managed care or the payer has that much control. But if the county really controls the dollars,
Sure.
with us, the county controls it, and the managed care gets what the county
Well, except the county
give it.
theoretically has some flexibility there too, because if they throw any county money in at all, do they? Right. But does the county add any county dollars to be? No, not really. So,
The county may have more base dollars to do
sure.
two other things that we may see the county would see the county's trying to cover a career, so we would see that.
Yep.
Yeah, but that's what the county would be Medicaid, it wouldn't be based on the rate that you would be getting, the value-based, that would stick to, they keep that over there for the
Yeah, I just think as soon as you add other funding streams in, it gives you flexibility, that's all.
They've done housing
And,
and other things, but
yeah.
that's separate.
right.
But it's, you know.
So more and more, what I think is they're going to, that the dollars will be consolidated into more and more sort of streamlined processes, because they're gonna, because healthcare and managed care companies are gonna say, how am I supposed to meet my quality objectives for these people if they're homeless and I can't get them affordable housing? So I need that tool and that ability to get my access to affordable housing or subsidized housing for people. Otherwise, there's no way for me to manage their health outcomes. And so we're moving in that direction. There's definitely still restrictions on it. There are definitely still careful considerations, limitations on what Medicaid dollars can and can't do. But in theory, the promise of value-based payments is that it will give you more flexibility in that area. Boy, you guys, you guys stuck with us all afternoon, and I hope it wasn't too disjointed, because we did sort of stray from our original plan, but we wanted to make sure we were responsive to your questions and issues and concerns.
And you'll have the PowerPoint,
Right.
so you can follow
Take your
along.
time, review this, ask questions if you want, follow up with Jen and myself. And we forgot to announce, I thank you you reminded me, Eileen, that I didn't announce at the beginning, which is we just opened our Philadelphia office this morning. We've been working in the region for a while, but our Pennsylvania office has always been Harrisburg based, and so just this morning we have some new colleagues who have joined in Philadelphia. I'm excited to spend a lot of time in Philly with them, working together, because we're going to end up back and forth on the train from New York to Philly. But there are folks here locally, a lot of folks who have the Pennsylvania context and knowledge, in addition to Jen and her colleagues in Harrisburg and the Philly office, and we're excited for that. So lots of people who can help you. If you have questions, give us a call. We're happy to follow up. And if there's stuff that we don't know, we have a lot of really smart colleagues who know things that we don't. So we'll connect you to them, and they'll answer your questions. And if if somebody needs more follow-up on the commercial side, that's not me, but I'll get you somebody, and we'll make sure you have resources to connect with.
Is your contact information?
It is the very last slide that we didn't get to you. These were our takeaways, of course, that we said, I think. But these are. Oh, Jen, I somehow don't have your number on here. Sorry.
Oh.
We'll add it. I don't know how that happened. Yes.
Yeah.
Sorry about that.
I'll give my card.
Email is there.
Who wants it. I have
Yes.
my card, so if
You have
anybody wants
cards.
to take, it has my.
Okay. Great.
Yes.
Final questions, comments? Nice endurance on this, guys.